three very experienced panelists. But I once again want everyone to feel that they are part of this, and it's a, it's as if it were you are in a common room or in a coffee room, and if you want to ask any questions, I just want you to feel free to ask. Don't worry about asking questions. So the first speaker is going to be Kenichi Nishiyama. He's director of neurosurgery at the University of Niigata. He's very experienced neurosurgeon, and also he's the president-elect of the International IFN, International Federation of Neuroendoscopic. So he's going to give us a lecture on how to use neuroendoscopy when there are shunt complications. So Dr. Halgate, thanks for joining us. So Professor Nishiyama, would you kindly share your presentation? Thank you, sir.
Yes, thank you. Okay, thank you, Naren. Good morning, good afternoon, but in Japan now it's a good evening. So it's a great pleasure for me to be here and talk in this strong, good webinar. So today's my talk is about the management strategy and surgical technique with endoscope for complication related to CSF shunt. Okay, no COI. That we sometimes call hydrocephalus repeat shunt. Maybe many have been frequently catch and call for shunt replacement on the weekend. And best shunt is no shunt. It is, so to speak, our cry of the soul. When you look back the history of hydrocephalus surgery, after 1970, design of the shunt changed to programmable and anti-siphon. At the same period, modern endoscope were developed. Maybe that is after the Hopkins, they developed Hopkins head rigid of the lens. Then endoscopic CSF diversion, especially ETV, became the main engine to treat hydrocephalus along with anti-siphon shunt. These are frequently indicated procedures for treatment of hydrocephalus in current state. I roughly classify those, the diversion CSF pathway, the coagulation or the removal of the cold plexus, the CPC, and brainwashing over the ventricular lavage, or shunt retrieval and shunt replacement. Maybe it's done with or without guidance of ultrasonography or navigation, and sometimes we use a stent. And diversion CSF pathway is classified as release of block in the ventricle, that is septostomy and aquileplasty, and ventricular cystinostomy, that is ventricular temporal ventriculostomy, and fenestration of the cyst wall. This schema is classification of the complex hydrocephalus for considering the treatment strategy by Dr. Anderson. He reported from the viewpoint of anatomical classification, uni and multi-located hydrocephalus. And here, the simple unilocated hydrocephalus is a classic obstruction hydrocephalus with a single point of obstruction or a single cyst and normal CSF absorption. Generally, single-stranded shunt is inserted, and also endoscopic CSF diversion carries a high success rate in this entry. Similarly, the simple multi-located hydrocephalus, their normal CSF absorption and no numerous compartment or distorted anatomy should also be handled by endoscopic CSF diversion and neuronavigation assisted cyst fenestration. Thus, these and the simple hydrocephalus is manageable with endoscope. And in case of shunt malfunction, endoscopic CSF diversion should be indicated. But the complex unilocated hydrocephalus goes beyond the pure anatomical obstruction and will not be manageable purely by intracranial CSF diversion. Also, the physiologically complex multilocated hydrocephalus always require shunt. So when you encounter shunt trouble in these conditions, the realistic goal is a single-stranded shunt. And in some simple complex multilocated hydrocephalus, there will be a need for repeated the fenestrations over time, and subsequent patient will require shunt systems. Thus, the shunt malfunction is manageable by endoscope in the case with simple hydrocephalus. As you can see, that we can convert into shunt independent with ETV to analyze how the CSF dynamics changes. I've inserted the EVD and measured CSF drainage volume in intraventricular anatomy, anatomically the obstructive hydrocephalus case. And in this study, EVD was set at 30 centimeters in water pressure and measured up to the maximum of 2 weeks. Then daily CSF outflow pattern was divided into 2 types, and one group showed almost no flow, but another group showed more than 150 milliliter outflow for several days after ETV, with presenting transient increased ICP symptoms, but decreased during a couple of days. Patients can convert into shunt independent during the adaptation period. When we compare the results between the patient's age of the initial shunt insertion and duration of shunt, those were not statistically correlated. And also we analyzed the changes in large isotope histogram between 1 week and 6 months following ETV and with shunt removal. Here, we checked the ratios of the RY count at 40 hours, so that measured at 5 hours after RY injection from the lumbar puncture. The result revealed the CSF dynamics is still changing during a half year after converting into shunt independency. So still now, I think it is impossible to measure so-called CSF absorption capacity before ATV. And in patients with this criteria, 5 years shunt ATV survival was the 84% in my cases. Thereafter, I've followed the long-term functional results with usage of quality of life scale, such as instrumental ADL or the EQ5D. According to that, good long-term outcome is considered to be more likely in patients undergone ATV or a shunt removal in patient for removal in childhood. Outcome is not dependent on the ventricular size, however, related to the presence of complicated brain damage or the brain dysplasia. Hereby, I'm convinced endoscopic CSF diversion should be considered to indicate for treatment of shunt malfunction as a first choice. One of the popular pathological states of shunt malfunction is switch ventricle syndrome, as you know. I myself always externalize the shunt at first, then open the ventricle to work with the endoscope. Basically, I use navigation or ultrasonography, and also this flexible endoscope with soft tip 1 to avoid injury of the ventricular wall. This is the successfully treated Dandy Walker cases. He was inserted CP shunt immediately after birth in another hospital, but I changed it to the VP shunt with aqueductal stent at he was 2 years old. Then I waited for the thickening of the brain mantle. When he grown up to the 6 years, shunt obstruction had happened. Then ETV with shunt removal was done. As you can in this slide and in video, you can see the stent. Stent is not adherent to the aqueduct. And after that, I insert the fiber scope to look the fourth ventricle, and I confirm the complete obstruction of the fourth ventricular outlet. That is a membranous obstruction. Then back to the third ventricle and down the ETV as a transition fashion. So finally, this patient was converted into shunt independent after this long period. So for pediatric neurosurgeons, Chiari is sometimes indicated to shunt removal, but its success rate is not so high. One of the reasons could be it's complicated the anatomical structure like this. For example, the slit or drop-shaped ramen of Monroe disturbed to insert the endoscope to the third ventricle, or very narrow flow of the third ventricle with sometimes with some transverse fold and thickener trabecular or lyricus membrane in the interpeduncular system. So in Chiari, carefree passage of narrow foramen Monroe and perforation on the transverse fold of the third ventricular flora, and then complete fenestration of the thickened trabecle and the system. These techniques are required for complete CSF diversion for shunt removal. So considering this effect of ETV, enough CSF space in the system before brainstem and foramen magnum will be required. So Chiari with tight posterior fossa is sometimes contraindication for me since CSF pulsation could now be buffering in the system. Yes. Okay. From the viewpoint of CSF physiology, ETV provides pulsatile pressure buffering and the spinal canal. Sometimes peripheral subarachnoid space is closed in shunted patients. We should check it before surgery after with CSF flow study. The other effect of ETV is to reduce transmount pulsatile stress. This causes the increase in the compliance of the brain, of the ventricle, sorry. This case is an infrequent but profound complication of the shunt Listserv midbrain syndrome. It is characterized by the kinetic mutism and Parkinsonism that develops in some patients after repeated changing of the initial setting pressure of the shunt. So when you apply ETV and convert into shunt independent, these symptoms improve dramatically like this. Okay.
Video, I'm not going to worry about why you're lowering.
Okay, according to the previous report, repeated attacks of ventricular dilatation and relaxation might somehow alter the physical characteristics of the tissue to permit expansion at lower pressure and more rapid dilatation. The damage to midbrain reticular formation and periventricular monoamine projection and periventricular terms and the hypotherms causes these strange symptoms. When we insert the endoscope, in 4 cases, we found the injury of the midbrain surface in all 4 cases like this. So endoscopic ventricular systenostomy, ETV, makes more physiological condition and resolve the symptoms with shunt-free. So endoscopic CSF lavage brainwashing was indicated as an initial treatment for the ventriculitis in some cases. In addition, endoscopic cold plexus coagulation, CPC, makes time for delay in shunt replacement and was indicated in infectious complication. The realistic goal of the ventricular lavage for the ventriculitis is to prevent developing a physiologically complex multilocated hydrocephalus and to provide early healing. According to our data, early indication of lavage reduces the time to the remission. Then since endoscopic ventricular lavage is effective, I think concurrent endoscopic CSF lavage and CPC could be one of the choices for treatment of refractory shunt infection. It will be the alternative to the replacement of antibiotic impregnated catheters or the ETV alone. This case is hydrocephalus complicated with shunt infection. At first, we ligation with artificial CFS as much as possible because of this operation. The purpose is changing the dirty CSF to the clear one. And I removed the choroidal grown spot with usage of the, this is a minor bent by manual hand cutting the grown spot, then coagulated the choroidal plexus. This time, not only the surface of the choroidal plexus, but also coagulate the choroidal artery, some branches. And following the procedure, the progressive enlargement of head circumference was arrested. According to changes in composition of CSF after the procedure, the cell count in CSF was falling down like this immediately. The level of CSF protein was increased and maintained high for at least 3 weeks. However, it normalized more than 1 month after that. So, sorry. This suggests that the transient inflammatory process could occur after CPC with CSF lavage, even usage of the artificial CSF. Probably this means any chemical inflammatory reaction because of presenting decrease in the cell count during this period. Otherwise, newly formed CSF would be produced even after CPC or so-called patient CSF turnover recovered. Because of the CSF production is not only the core plexus, but also the neural fluid could be moved from the interstitial fluid in the parenchyma via ependyma. In addition, maybe the CPC reduced the CSF pulsation that has expanded ventricular system. Although the CPC can be beneficial in reducing the need for shunt, I personally still do not feel that I could confidently recommend CPC without a very detailed discussion of the possible long-term risks because of its several functions, such as immune surveillance, because that could be such an entry point for the immune cells to fight intracranial infections, and chemical surveillance. That means a sensing function to some stress or the inflammation and neurogenesis. The core plexus provides some biological active molecules for neurogenesis in the ventricle and impacts brain homeostasis and also circadian clock. I think there are not enough studies yet on long-term outcomes or risks about these functions. Thus, I indicate endoscopic lavage with CPC only for severe hydrocephalus with the poor prognosis or refractory shunt infection cases. Okay, with many endoscopic procedures options applicable in cases with shunt malfunction, it is just a matter of making a hole and cutting the membrane and the burning the surface. However, in general terms, there is a clear steep learning curve in endoscopic surgery. So it is important to have training in anatomical understanding and hand-eye coordination. I believe all neurosurgeons can do it as a basic procedure, similar to a shunt, and indicate in the case with shunt malfunction. Okay, in my conclusion, the endoscopic procedures should be considered in the first place for treatment of shunt-related complications. The main objective is resetting of a simple CSF shunt, however, converting to shunt independency with resolution of symptoms might be possible in certain cases. And it is essential to analyze anatomical structure in detail before CSF diversion with shunt removal to secure the safety and effectiveness. Thank you for your attention.
Thank you very much, Professor Nishiyama. That's a very important talk that once again looks at endoscopy and how important in hydrocephalus patient and different indications. I just want to first of all bring Professor Chandrasekhar Deopujari for his questions and comments for Professor Nishiyama. Thank you, Prof. Prof, I think you're on mute, Professor Deopujari.
Sorry.
Thanks.
Nice talk, Kenichi. I think you covered a very difficult kind of a topic, though there are more and more papers coming out of the fact that many of the shunt-related problems may be treated with endoscopy with some success.
Mm-hmm.
There are certain things which I think you have shown which are a little different. First of all, the equipment used. I think you are using mainly the flexible endoscope for all the procedures. Is that correct?
Yeah, but as I show you, sometimes I use the rigid endoscope because of sometimes we cut some mass or the cutting the wide membrane or so. But in the flexible endoscope is go to the ventricle all around the ventricle. It is very useful to do the CSF diversion operation. I think so.
Two other questions quickly about the post-infective kind of hydrocephalus. One is, of course, your personal experience with ventricular lavage. What are your indications and how useful have you found it?
Yeah, actually, I don't want to make the complex hydrocephalus after ventriculitis, of course, and all you are, but it's not easy. So for me, the indication of the ventricular lavage is when you check the CT or the MRI, I can see the needle in the lateral ventricle. At that time, I inserted the endoscope.
And the choroid plexus coagulation, which you talked about, do you restrict that for cases like holoprosencephaly, or do you also use it for post-infective and other hydrocephalus?
No, I only use very severe hydrocephalus. That means almost hydroanencephaly or proportionencephaly. That means that is not the good outcome. I mean, the outcome, the poor prognosis of maybe the functional prognosis is not good. In those cases, I use the choroid plexus coagulation.
Over to you, Ricardo.
Okay, thank you. Kenichi, your talk was really very clearly. And I have Chandra talk about choroidal plexus coagulation, and I would like to reinforce that is this technique is still on debate on literature. And do you usually perform choroidal plexus coagulation for infants in add with the ETV?
No, but that depends on the cases. So maybe in the infant, ETV is not so effective because you mean that because maybe under the 3 months old or so. At that time, I only choroid plexus coagulation and irrigation only. And after the baby grown up, I removed the shunt and doing the ETV at that time.
Okay.
And yes.
Yeah. I have another question. When you showed the neuronavigation for a slit ventricle, do you usually do you use the electromagnetic neuronavigation?
Yes. Yes,
yeah.
of course. Yes.
Where?
Yes,
okay.
Of course. Yeah.
When you use the electromagnetic, do you have some problems with artifacts when you are navigated with the ridge endoscope or not?
Oh, no, I don't have not problem. And also, I not only use the navigation, but also with usage of ultrasonography also. Always, I use a two navigation system. You mean not only a neural navigation and also ultrasonography. Ultrasonography is very useful by means of that to in the live. I saw the live views during the operation.
Okay. And my last question is: do you usually perform the CSF punction, lumbar punction, after an ETV in infants, or when you remove it a shunted? In your beginning of your talk, you showed some symptoms and some signs in patients after neuroendoscopic procedure. So how will you manage in these patients that present some signs or symptoms?
No,
red aches or vomits and some intracranial pressure signs after, for instance, removal of the shunt.
Yeah, I did the lumbar puncture only for the cases with the ISP signs. maybe a couple of days after the ETB. That I showed the data that is only the study. So basically, I do not perform the lumbar puncture after the ETB, but in some cases, maybe after ETB the next days, he explained the headache. So at that time, I doing the lumbar puncture.
Okay, for select patients, so.
Yeah.
Yeah. Thank you.
Welcome.
Thank you, Ricardo. Dr. George, your comments and questions for Prof.
Kenichi,
Nishiyama.
that was an excellent presentation. You know,
Thank you very much.
I've got a couple questions, but maybe Naren, let's get to the questions that people have posed. I think I see a couple of hands
Sure.
up.
Sure.
And if we have time, I'll ask them. Otherwise, I'll just text you my questions.
That's okay. That's okay. Mr. El Gamal, do you want to ask your question, please? You should be able to open your microphone.
Oh, yeah, actually, it's one of the complex cases, 5 years old with hollow prosencephaly, multiple shunt revisions due to obstruction and infection. One of the revisions, he developed fecal fistula. He ended by having a VA shunt, which worked for a few months. His protein has been always high, and he came again with shunt malfunction. Tapping I left an anomaly reservoir in the last VA shunt. Tapping the reservoir improves him. Then he goes back again into lethargy and raised intracranial pressure. So I wonder what's next. He has a VA shunt, which is not functioning very well, and I believe because of the high protein. And he has an anomaly reservoir. I connected it to an external drain system now. CSF is xanthochromic and cloudy. I wonder if I put an endoscope, am I going to see anything? Do you think CBC can help, or lavage or endoscopy? I don't believe endoscopy can help in this case because the brainstem is stuck to the clivus. So I wonder, is there any advice for this case?
It's a very tough case, I think, of course. But the realistic goal is you put a single-stranded shunt, and before that, you should doing the brainwash and ventricular lavage, and many times, and at that time sometimes I don't know the detail of that case. Maybe I introduce the CPC with washing.
That's great.
Okay, thank you.
Dr. Kumar from Bangladesh, Dhaka. Dr. Kumar, do you have a question?
Thanks for giving me a chance for asking a question. That my question to Professor Kenichi, that you told us that you use neuronavigation during the endoscopic procedure. Can you please have the neuronavigation for your flexible endoscope?
No. The flexible and in the flexible endoscope, we cannot connect to the neuronavigation, of course. That means that I say that I use the ultrasonography. We have this is my opinion. We have the two kinds of the navigating the guidance system. That's one is the neural navigation or the ultrasonography. That's the physical navigation. Otherwise, the chemical navigation. For example, the fluorescein at 5 hours or so. I think so that in flexible endoscope, we cannot use the neural navigation system. I only use the ultrasonography.
Thank you very much.
Yeah, welcome.
George, can I come back to you, please?
Navigate.
Yeah, I don't know it's how small, but all cases they externalize the shunt at first, and then they wait for a moment and they increase the ventricle size a little bit, and then attach to the ultrasonography. Sometimes the infusion of the CSF a little bit and expand the ventricle, and they introduce their endoscopic sheath at the contralateral side. I have no problem. this.
Okay. And how long do you wait to increase the ventricle size? If you
That
externalize,
depend on the case. So before the DCTB and the shunt neurosurgery, maybe the day, 2 days or 3 days before, I check their ventricular size. When I go to the hospital in the early morning and they clamp the ventricle and the EVD, and after maybe the 1 hour or 2 hour after the check the MRI and to see the size and to see his symptoms, and I predict the duration of the EVD stop time.
yeah, excellent advice. Thank you.
Thank you very much. If there's any more questions for Professor Nishiyama, would you please post it on the chat box? Thank you very much, Professor Nishiyama. This was fantastic.
Thank you. Thank you. It's
A lot
very
to-
great
lot
praises.
to-
Thank you so much. Yeah.
A lot to study from, and at least it's recorded, so I will put it hopefully on the YouTube soon.